Today my topic is about Pilon fractures. I was lucky enough to be the author of the Pilon chapter in the AO Principles of Fixation textbook in the edition 2018. And when you see a fracture like this, what are the questions that come to your mind? First of all, what is the fracture configuration? So we need to review new classifications. Would I do this fracture acute, open reduction, or stage protocol? Fibular fixation, do we need to do it or not? And if we need to do it, we do it early or late? Which approach to use? And finally, fixation options and column support concept. And these are exactly our learning objectives. So the questions that come to your mind are the questions we're going to answer through this lecture. But before starting, I would like to remind you of a very important sentence published in 2010 in the Journal of Engineering, a comprehensive review of literature by khaled that said that there is not an ideal there is not a single method of fixation ideal for all Pilon fractures and suitable for all patients. And that's why when we see x-rays of Pilon, we will see all this variety. And also nowadays we use a fixation concept called fragment-specific fixation, and that's why in many cases you will see all different sorts of plating and nailing options. To start with, the classic classification of the AO divided the distal tibia into type A, B, and C. However, a new and modified fracture classification compendium was published in the Journal of Orthopedic Trauma in 2018, and I would invite you all to have a look at it. And in 2010, we had this very useful, 2012 actually, we had this very useful column classification published by a Chinese team. And this column classification is very important to us nowadays because the classic rules by Rudy and Al-Gaur were to fix the fibula first, to reduce the length, rotation, and angulation of the fibula and fix it, reduce articular surface, graft the metaphyseal defect, and then put a medial plate. But nowadays, after this classification, we do not always put a medial plate. The column will dictate the plate position, so we can put an anterior plate, lateral, medial, or posterior. The stage protocol, so doing an early spanning external fixator plus minus fixation of the fibula, and then doing later definitive open reduction in 7 to 17 days, what we call the span, scan, and plan, yielded better functional outcomes, lower soft tissue complications, and higher clinical outcomes. And this was proved in all the publications you see down there. However, nowadays we say early spanning external fixator plus minus other steps, because it doesn't always have to be a fibular fixation. So we usually do a CT before the spanning, so we call it now scan, span, scan, and plan. I will give you an example of the additional steps we do with the early stage fixator. Sometimes we do a fixator with a primary fixation of the fibula. Sometimes we do a fixator with early fixation of a simple articular component, changing a 43C into a 43B. Sometimes we do an early fixation of a simple metadiaphyseal component, changing a 43C to a B. Like this example, you can see here a long metadiaphyseal fracture that was fixed by 2 screws. And these are cases by Matt Graves and Sean Moore. And this changes the 43C into a B. Another example is fixing a posterolateral fragment or a medial fragment going out through an open medial or posterior wound so as not to need to go back to this incision again. This is an example of an open medial fracture. This was the branded fixed on the medial side with the spanning X-rays. Acute definitive open reduction started to be published again, or started to be back in fashion since 2010, 2012, and 16. And it had certain conditions. It has to be a minimally soft tissue injury, low energy fracture within the first 24 to 48 hours and done by an experienced surgeon. I will give you this example. This is a 25 years old female that I operated 50 years ago. This is her fracture on the CT, and this is her soft tissue condition the day of the fracture. It was an excellent soft tissue condition, so I chose to go with an acute open reduction, a medial approach and a medial plate for the medial column fracture that you see here. We use this medial plate, and the anterior plate for this important component. And I'll explain to you why we have an anterior plate. This is the anterior plate and a rafting screw, and this is very important to be done, and the important thing is to have a coverage of the talus. So we need to have this reduction achieved to cover the talus. Otherwise, on the long run, after 2-3 years of follow-up, the talus will extrude anteriorly. Fibular fixation, is it essential to be done or not? Yes, because it is basically the first rule of the Rudi Aldau. Number 2, it reduces the key anterolateral support fragment. Number 3, it is a lateral column support, so it increases mechanical stability, and it reduces the syndesmosis, which is very important for us. Always fix it first. This is the rule that we learned, but let me give you this example. Would you always fix it first? I don't think so. I think in this case, I would delay it for a definite open reduction. So the fibular fixation can be done acutely, if simple, or oblique, and this is in 60% of the cases. In this case, you will fix it primarily. If comminuted, you may delay it to the definitive. If you are not the surgeon who will do the definitive open reduction, please do not do the fibula and transfer the patient. If you are not sure about the approach you will use for the definitive, don't open the fibula, because this might burn bridges for your definitive approach. And the most important of all in the rules is that if you fix it right. Because if it's rotated, if the length is not reduced, if it's angulated, then you will never be able to reduce the tibia in the definitive open reduction. It can be done using a plate, or can be done using a nail. It can be done open or minimally invasive, as published by Christoph Sommer and Hess in 2011, and they found successful results in their cases. The surgical approach for the Pilon is mainly dictated by the fracture pattern. So we look where we want to access the fracture, where we want to look at our fracture pattern. The second thing is the mechanical appropriate position of fixation, and I'm going to go into details into this point. So if we have a varus failure, in this case, the medial column fails and the talus wants to go medially, so we need a medial plate. For a valgus failure, we need definitely a lateral plate. And always we think about where we want to put our plate by the direction of the arrow, or the direction of where you want to put your thumb to reduce the talus. The same thing applies to the direction of talar extrusion. So for a fracture like this in the anterior column, the talus wants to go anterior, so we want to put a plate anterior to prevent this. And for a case like this, we want to put the plate posterior to prevent the talar extrusion posterior. The third and most important factor dictating your approach is definitely the soft tissue condition. And we always knew that the anteromedial approach is the workhorse for all Pilon fractures, but unfortunately, most of the soft tissue bad injuries are on the medial side or the anteromedial side. So most of the surgeons doing Pilon want to go away from the anteromedial side, and that's why you will find most of the surgeons doing Pilon in the US and Europe going to the anterolateral or posterolateral approaches. And to avoid soft tissue stuffing, we always learn the rule that we have to have 7 centimeters between incisions. However, the group from Seattle, from Harborview Medical Center in Seattle, Washington, Sean Rhodes, Stephen Benirsch, James Howard, Julie Agel, and Stephen Benirsch challenged this rule, and they said that they had 83% of their cases having an incision, 2 incisions less than 7 centimeters away with a mean of 5.9. They had 46 cases, only 4 had minor soft tissue problems. But the incisions were done at different stages, and the angiosome should be considered. So what are the angiosomes? The angiosomes are 3D vascular territories, and between the angiosomes we have bidirectional blood flow. So if we do an incision in this angiosome and an incision in this angiosome, and they are very close together, still we're going to have good blood supply between the two. Closure of the wounds in Pilon, always modified at Gower-Donati stitch. Nowadays, this was published 2017. They found that this produces a better perfusion, and this is a modified Gower. We go far away from the incision on this side. We go deep far away and then close in the subcutaneous tissue and go out close. The only difference between the modified Gower-Donati stitch and the vertical mattress is that in the vertical mattress we go out on the skin and back again. In the modified Gower-Donati stitch, it's all in the subcutaneous tissue. We don't go on the skin and back again. And this was published 2017 by Shannon et al. And they found that it affords an improved perfusion for the skin in all ankle, pilon, and calcaneal fractures. So that's why since then I've been using this stitch and it has very good outcomes. And the more important is that we used to use staples for ankle fractures. Please do not use staples. And this was proved in the paper that it yields less perfusion. So the fixation, we come to the fragment-specific fixation as I showed you. And as we said, there is not a single method of fixation ideal for all pilon and suitable for all patients. So I'm going to speak about some papers that compare the outcomes. For example, locked versus non-locked. This was published in the Journal of Orthopedic Trauma in 2015, and they found no difference in long-term radiographic outcomes. Names for the Pilon, this was published twice, once in 2012, and they said that it's for simple articular comminuted metadiaphyseal without impaction, and it should be done by an experienced surgeon after careful examination of the CT for the articular part. Again, it was published in 2013, and they said that it's a reasonable option for grade 43, C1 and C2 by an experienced surgeon with a relatively low comminution of the articular surface and it yielded low complication rates. Nails versus MIPO, this was published in Turkey, 2017. They operated 37 cases with intramedullary, 36 cases with MIPO, and all were 43 C1 and C2, and they found that both had successful functional outcomes. However, valgus malunion was more with the nail, while recurvatum was more with the MIPO group. Definitive external fixation, and this is, of course, is favored by our friends who do the circular or ring fixator. This was published many times, and I found in the literature many reports of it. And they found that it yields a high union rate. This was published 2010 and 16. They found pin-tract infection common, but osteomyelitis and deep infections were extremely rare. It's not reliable for central impaction or central depression, so limited internal fixation is added, but the meta-analysis found no difference in the infection rates. So my take-home message is fracture configuration. Remember the new classifications. Acute versus open, still stage plus minus open reduction in very limited cases. We should fix the fibula early or simple late if comminuted. And the approach relies on the fracture pattern, soft tissue condition. Fixation options should be fracture specific. And finally, there is not a single method of fixation ideal for all pilon fractures and suitable for all patients. Thank you very much.
Thank you very much.